You know, urinary tract infections in kids, they're incredibly common. But what if I told you that our whole understanding of what causes the real, long-term damage might have been, well, a little off for decades? It's time to uncover the hidden story behind pediatric UTIs.
For the longest time, the medical world pointed the finger squarely at UTIs for causing long-term kidney scarring in children. But you know what? Newer research is completely rewriting that script. It turns out we may have been putting all the blame on the infection itself, while kind of missing a much bigger piece of the puzzle. Things like congenital abnormalities. Now, don't get me wrong, UTIs are still super serious, but that link to permanent damage? It is way more complicated than we ever thought.
And just to give you an idea of the scale we're talking about, it's just staggering. Here in the United States, pediatric UTIs account for 1.1 million outpatient visits every single year. I mean, just picture that. Millions of sick kids, millions of worried parents, and millions of doctor's appointments, all because of this one condition.
And of course, those 1.1 million visits, they come with a truly massive price tag. Over $500 million in hospital charges annually. So yeah, this isn't just some common bug going around. It's a major public health issue with a huge economic footprint.
So how does this whole thing even start? How can a tiny, microscopic organism cause so much chaos? Let's walk through the invasion, step by step, to see how a typical UTI really takes hold in a child's body.
All right, this bacterial invasion pretty much follows a set playbook. It all kicks off with contamination, usually when gut bacteria find their way to the urethra. From there, they start climbing. They've got these specialized tools that let them latch onto and burrow into the bladder wall. Our immune system, of course, sounds the alarm and fights back. But these invaders are smart. They can hide, they can multiply, and they can even build these little protective fortresses called biofilms to fend off our defenses. And if we don't stop them, the invasion continues upward, all the way to the kidneys. And that's where the real trouble can begin.
In this diagram here, it shows you that entire invasion route. You can see the whole journey. But honestly, the most critical part of this whole process is that jump from the bladder up to the kidneys. That's the turning point, where a simple infection can morph into a serious threat to a child's long-term health. It's basically a visual roadmap of the whole assault.
So you have to wonder, why do some kids get UTIs while others don't? Is it just bad luck? Not at all. It's more like a perfect storm of factors, involving both the specific bacteria and the child's own body. Let's break down what those key risk factors are.
First off, it is absolutely crucial to understand that not all bacteria are created equal. On one side, you've got the highly adapted invaders. These are the virulent, uropathogenic bacteria. Think of them as the special forces. They're responsible for about 80% of E. coli UTIs because they have this whole arsenal of weapons designed to cause disease. Then, on the other side, you have the residents. These are the commensal bacteria that usually just hang out peacefully in the gut. They can cause a UTI, but they just don't have that specialized toolkit their more aggressive cousins do.
To really get how these bacteria are so darn effective, we gotta look at their toolkit. This image shows one of these uropathogenic E. coli cells latching onto host tissue. All these different parts you see, the little hairs for gripping, the toxins for doing damage, the capsule for defense, they all work together to make this bug a really formidable invader.
Let's really break down this arsenal. Fimbria, they're basically grappling hooks that let the bacteria cling to the bladder wall so they don't get flushed out. Aerobactin, get this, is a specialized system for stealing iron, which is a vital nutrient, right, from our own bodies. They also unleash toxins that directly damage our cells, and they use a capsule as a kind of stealth shield to hide from the immune system. And if all that wasn't enough, they can form those biofilms, which are incredibly tough to get rid of. But look, the bacteria are only half the story. The child's own body, the host, plays a massive role here too. Age is a huge factor, with infants being the most vulnerable. Sex is another one, with this really fascinating switch. UTIs are actually more common in boys under 1, but after that they become overwhelmingly more common in girls. And then there are other factors, from circumcision status to even functional things like constipation, that can create the perfect environment for an infection to really take hold.
And that point about circumcision is just wow. The data is pretty clear. In the first 6 months of life, being circumcised is linked to an almost 10-fold reduction in the rate of UTIs. It's one of the most significant host factors we've identified in baby boys. Okay, so we've got these really well-armed bacteria and a whole range of host vulnerabilities. The next big challenge is, how do you figure out when an infection is actually happening? And that brings us to the tricky puzzle of diagnosis, which is especially tough in little kids.
This is really the million-dollar question for pediatricians and parents everywhere. I mean, think about it. A baby can't tell you, hey, it hurts when I pee. They can't explain what's wrong. So how on earth do you pinpoint a UTI when the signs can be so subtle and honestly could point to a dozen other things?
You see, the diagnostic challenge is really all about age. In older, verbal kids, the symptoms are pretty classic. Pain when they pee, needing to go all the time, maybe some new accidents. But in infants, oh man, the clues are super vague. We're talking fever, being extra fussy, not wanting to eat. I mean, that could be anything. This is exactly what makes diagnosing UTIs in babies so incredibly hard, and why doctors have to be real detectives.
So, to get more concrete evidence, we turn to urine tests. The first one is the leukocyte esterase test. Basically, it's looking for white blood cells in the urine, which is a big sign of inflammation. Now, here's the key part. It has high sensitivity, which means it's really good at catching potential cases. If it's negative, a UTI is pretty unlikely. But its specificity is a bit lower, so a positive result could be from other things causing inflammation, not just a UTI. The second key test is for nitrites. See, certain bacteria turn nitrates in our urine into nitrites. This test has crazy high specificity, like 98%. That means if it's positive, you can be almost certain you're dealing with a bacterial UTI. But here's the catch. Its sensitivity is low. A negative result doesn't rule out an infection, especially in babies who pee all the time, not giving the bacteria enough time to actually make those nitrites.
But honestly, none of these tests mean a thing if the urine sample itself is contaminated. And this is so important. A sample collected with one of those little adhesive bags, for example, can have a false positive rate as high as 75%. That's huge. It means that for a truly reliable diagnosis in young kids, getting a clean sample, usually with a catheter, is often the only way to be sure.
All right, so once a diagnosis is finally confirmed, the focus shifts immediately to a quick and effective response. So, how do we treat these infections, and what does the path forward look like to prevent them from coming back? When it comes to treatment, the goals are super clear and straightforward. Goal number 1, you got to get rid of the bacteria causing the infection. Simple as that. Goal number 2, the big picture one, is to prevent any permanent damage to the kidneys. And goal number 3, of course, is to just make the poor kid feel better by relieving their symptoms.
Now, I really can't overstate how urgent treatment is. Just delaying antibiotics by a few days, say from day 2 to day 6 after symptoms start, can cause the risk of permanent kidney scarring to skyrocket from 11% to a staggering 76%. This is exactly why any unexplained fever in a young child needs to be checked out, and fast.
And treating these infections, it's not a quick fix. A simple bladder infection might just need a few days of antibiotics. But a febrile UTI in a child, one with a fever, suggests the kidneys are involved, and that requires a full 1 to 2 week course of antibiotics to make absolutely sure the infection is knocked out completely.
And even after the infection is gone, the job isn't done. Parents need to know that these things can come back, especially in the first few months. So any new fever needs to be taken seriously. It's also key to address any underlying issues, like constipation, that can make UTIs more likely. Really, it's all about working with your pediatrician to manage that risk going forward.
And that brings us to what's next, the future. You know, for years, we all thought urine was sterile, but now we know there's a whole community of bacteria that live there, the urinary microbiome. So here's a final thought to leave you with. What if, instead of just fighting off the bad bacteria, we could actually encourage the good ones? Could a whole new generation of tailored probiotics become our best tool for preventing these infections before they even have a chance to start? It's a pretty fascinating question, and the answer could totally reshape how we handle pediatric UTIs for years to come.